Well, we're about to wind down to the end of this incredible day of information about African American and Black health. And we're going to address sickle cell disease again. And this time we're talking in terms of the inequities and ensuring access to healthcare for people with sickle cell disease. Obviously, we discussed before, can cause patients extreme amounts of pain and discomfort. While many advancements have been made in the treatment of the disease, we must strive to ensure patients have equal access to quality health care. We have two experts in the area, and we want to welcome Dr. Angelica Chala and Dr. Brett Girard as they discuss the ways in which we can ensure proper health care for those affected by sickle cell disease. Dr. Chala is a senior medical director in medical affairs at the U.S. SCD and the U.S. SCD lead at Bluebird Bio. She's also a practicing pediatric hematologist and a uro-oncologist for about 20 years at the Hasbro Children's Hospital in Providence, Rhode Island. At Bluebird Bio, she leads the sickle cell medical team, bringing the patient and provider voice to guide in development of clinical trials and to determine and communicate what gene therapy could potentially bring to address these issues. Dr. Brett Girard is a physician, scientist, and innovator whose career has been dedicated to improving public health and medicine. Formerly, he served as the 16th Assistant Secretary for Health in the U.S. Department of Health and Human Services, as an acting FDA commissioner and admiral in the U.S. Public Health Service Commission Corps. Dr. Girard has received numerous awards, including the Sickle Cell Community Consortium Healthcare Champion Award, among other awards for his outstanding work in healthcare. We welcome you both. Questions that you may have for participants in the Q&A throughout the session, and we're ready to rock and roll. Thank you so much for joining us. We appreciate it.
Thank you, Colin. Thank you for that kind introduction. I want to thank Black Health Matters, Bluebird Bio, and Dr. Girard for the opportunity to discuss health inequities and how we can all work together to ensure equitable access to optimal healthcare for all those living with sickle cell disease. I can go through these titles again because they are just outstanding on Dr. Girard's behalf, though I'm going to have him speak on it a little bit as well. He's the former Assistant Secretary for Health. He is a U.S. representative to the executive board at the World Health Organization. He's an acting FDA commissioner and admiral of the U.S. Public Health Service. And he also, as stated before, is a big champion for sickle cell disease. We'll ask him to jump right in and talk a little bit about the Nasam blueprint and strategic plan, which is it's the National Academies of Science, Engineering of Medicine that was published back in 2020. Already 2020, COVID's made everything go by very quickly. It laid out detailed strategies and specific actions for improving care for people with sickle cell disease. This was a capstone for Dr. Girard, as far as I'm concerned, for all that he's done for the sickle community. And if it's okay, I'll have you jump right in and talk a little bit about the Nasam work, as well as your work with the Office of Minority Health, Department of Health and Human Services in the service of sickle cell disease specifically.
Well, thank you so very much. And it is an absolute honor to be here and a pleasure to be here. One thing you didn't know about me is I'm a pediatric ICU physician, and at one point was the chief physician in the Children's Health System in Dallas. So I had enormous amounts of experience taking care of children living with sickle cell disease and their families. And also why I'm so passionate about this area is my wife and I became the mentor of a young child who had sickle cell disease. We started being her mentor when she was 6 years old. She now is an adult. Her name is Shamanika Wiggins. and was one of the Sickle Cell National Advocates of the Year Award. So I really grew up with this, although it's not in my personal family. She's like a third daughter to me, and thus my passion for it. I'm going to share my screen with you if this works, and go through a few slides while we're here. So again, thank you very much for the opportunity to be here. Let me see if I can get this actually to work. Okay, here we go. So I want to talk just first of all, why sickle cell disease and why now? And you may have heard this earlier during the day, but 100,000 Americans suffer with sickle cell disease, and between 1 out of 11 and 1 out of every 13 African Americans have the trait for sickle cell. So there's almost no African American family or Mediterranean family or people from many parts of the world who this does not impact. There are millions of people worldwide, and something that people don't understand is sickle cell disease didn't exist until the first genetic mutation, which has been traced to 7,300 years ago in one child who lived in the Sahara Desert. But the Sahara Desert was then green. And what that gene allowed this person to do was have an advantage against malaria. So if you have the sickle cell trait, you are much less likely to die from malaria. So the sickle cell trait began propagating all through the areas where malaria existed, and it became worldwide. If you have one copy, you're very resistant to malaria. If you have two, you have the disease. As you heard, people with sickle cell disease suffer shortened life expectancy and multiple severe complications, including acute and chronic pain, and this can be awfully severe. One thing we're talking about here, and I will demonstrate this to you, is that the care for people with sickle cell disease remains very fragmented, and I would say embarrassingly poor quality of care. This is often not true for children who are fortunately taken care of by pediatric hematologists like Dr. Chola, but once a child gets into their mid-adolescent years and they sort of get lost from the pediatric systems, the care is really fragmented, and there's trouble right at the time when they need more care than any. It is very well documented that people with sickle cell are subject to discrimination in the healthcare system. In fact, I think it's the most well documented of any condition where there's obvious discrimination, and you can look at emergency rooms anywhere. But it's even more so now because of the opioid epidemic. Because of people have such tremendous pain, they often require large doses of opioids just to get through a crisis. And this has fueled more discrimination, thinking that people with sickle cell have drug-seeking behavior when they're really just trying to survive their incredible pain. Access to promising new therapies are already being jeopardized, and this is very concerning to me, that finally, after 40 years, we have a couple of new therapies, and I'll talk about them, but the access is being jeopardized by all kinds of criteria at the state level that, although they're paid for, there's all types of pre-authorization and all kind of paperwork that people have to go through so that these new therapies are not getting there. Very exciting. We have potentially curative gene therapies, and Bluebird is one of the pioneers in this area. They can't talk about it, but I'm very hopeful that they will have a gene therapy by 2023 that could provide really essential cures to many people with sickle cell disease. It's not going to be for tens of thousands of people because it's still very technical, but it's a first start. And I would say there's growing national enthusiasm among lots of groups, but we can't fragment ourselves or we're going to lose everything that we're trying to do. This is Shamanika here on the right side with, in the lower right, in one of my favorite pictures of her and a few of the warriors that I deal with on a regular basis. So when I got to Health and Human Services in February of 2018, I made sickle cell disease one of my priorities and assembled a sickle cell federal working group with all the agencies at HHS that really had a stake, and recruited now Rear Admiral Felicia Collins to be the Deputy Assistant Secretary for Minority Health. She was Captain Collins then, now she's Admiral Collins, a Boston Children's trained physician who is really still leading the charge in minority health, keeping these groups together, focusing on everything we need to do for patients. We made it our goal, and I think it's a reasonable goal that all of us should get around, is that although the life expectancy of people with sickle cell is in the late 40s right now, and many people die in their 20s, tragically, we have the ability, and I mean this, and I'm looking at you, Dr. Chawla, because Bluebird is one of the groups that could help this. We have the ability to normalize the lives of Americans with sickle cell disease within the next 5 to 10 years. And that means eliminating the suffering, eliminating the shortened life expectancy, and providing full quality of life. And we're all dedicated to that. At least I hope we are all dedicated to that. There's no more noble cause. When I was FDA commissioner, I was only acting for 3 months, but I had the privilege of accelerating even beyond their accelerated approval, the approval of 2 new therapies for sickle cell. It's one thing that I really feel very proud of, and this is part of the good news. And I will talk about the not so good news, but these 2 therapies are really making major changes in people's lives. And as I said before, never has there been so much enthusiasm. In 2020, the NIH put about $110 million into sickle cell related research. And it's probably double that with companies like Bluebird doing more research on their own to provide cures, potential cures for sickle cell. Now, let me tell you of the bad side of this, because I've talked to you about the positive side. We all know that care for sickle cell has been awful and fragmented. But what I was able to do as Assistant Secretary is ask the Center for Medicare and Medicaid Services to pull all their data from all over the country. It's never been done before on everyone living with sickle cell who are covered by Medicaid or dually covered by Medicare. And let me just give you an example of this report. It was published in September of 2020 during Sickle Cell Awareness Month, and it looked at data from 2017. But if you look at the left side, children under 16 are recommended to have something called a transcranial ultrasound screening once a year to know if they're at risk for strokes, and then they can go into treatment protocols. Only 1/3 of children receive this type of screening. If you look in the middle, one of our main therapies is hydroxyurea. And not everybody with sickle cell disease qualifies for hydroxyurea, but at our best centers, often 60 or 70% of patients are on it. If you look nationally, adults, only 10% of people with sickle cell actually got hydroxyurea at the levels they needed. And striking to me, less than 60% of children had a vaccine against pneumococcal disease. And we know that children with sickle cell are very likely to die of bacterial sepsis due to pneumococcal disease. It's a bacteria. So these are some of the ugly things that we all have to combat. As was stated, I knew whether I was in the administration for 3 years or 7 years, there would be changes in the administration. And one thing that I did, and I would encourage everyone to download at least the summary, was sponsored about a $2 million effort by the National Academy of Science, Engineering, and Medicine, which is nonpartisan. It goes from the Trump administration to the Biden administration to the next administration, to study for 18 months and bring everyone together to have a shared vision and a long-term policy plan for how to make the lives normal for people living with sickle cell disease and sickle cell trait. And this is a very, very important document because it outlines over the next 5 years how we could do exactly what I put in my one of my first slides about normalizing the lives. And it assigns tasks to everybody. And I'm not going to go through this. It's about a 500-page report. But the most important thing we need to do with the report is not let it sit on the shelves. So one thing that we are doing, I am now out of the government, but have joined a nonpartisan healthcare policy group. And when I say nonpartisan, it's really bipartisan. There's leaders from the Obama administration, from the Trump administration, from the Bush administration, that we have formed another sickle cell partnership to basically make sure that the National Academy's blueprint doesn't gather dust on the shelf. It's to really make the policy changes through Congress, and we want all of you to join with us to make the policy changes, to make that document real and to achieve our vision. I'm not going to go through everybody we have because we're just kicking this off, but we have patient advocacy groups. We have manufacturers like Bluebird who are pushing the envelope on new care, healthcare providers. We do have payers, the people who pay for it, subject matter experts, and contributors. And we are working on policy development in these areas, and not just development, because we have a lot of the policies developed. It's really implementing them. And let me just highlight a couple of areas. Workforce. We need more people in primary care who understand how to take care of underserved issues, particularly sickle cell disease. People with sickle cell can't see a hematologist every time they're sick. They need primary care who know. But we need more hematologists like Dr. Chawla, particularly adult hematologists. We need payment models because gene therapies are going to be expensive when you start. They may be $2 million or more, but remember how much you paid for your first computer. You paid thousands and thousands of dollars for something that is 1/1000th as good as your cell phone. Gene therapies will get less expensive, but we have to pay for them up front so people can get them and we can learn how to bring the price down. Data, we need better data about everyone in the United States to make sure that they're getting equal access. Healthcare delivery and access, big problem. Just to give you an example, the federal government has had a demonstration project on how to care for people with sickle cell with only $4 million a year, and it stayed stable for the last 14 years. That program needs to go from 4 million to 150 million. It demonstrated it works. What are we sitting on our hands for? Quality standards to make sure everybody who's covered by Medicaid or Medicare gets their hydroxyurea, gets their transcranial Doppler, gets their vaccinations, and finally accountability. And I mean this, who are we going to hold responsible in Washington to make sure that this is done? My suggestion is the Secretary of Health and Human Services. It should be a cabinet level person that needs to report out to you, the people who are concerned about this issue every year, maybe at this conference, about the progress that are being taken. So I'll stop now, but wanted to give you some of my thoughts and how important this is and why the time is now and how I am delighted, privileged, and honored to share this time with you. Thank you so much for the opportunity.
Oh, thank you so much. That it sends chills down my spine. When I first started going, getting interested in sickle cell disease, everybody kept saying, "Are you crazy?" Everybody's, these folks are in pain. That it's a genetic disease. There really isn't a cure. Why are you getting into this? And it's fun to see so much changes. Transplant has come a long way. Our improvements with transfusion medicine has come a long way. And as you said, one of the needs that's growing is people growing into adulthood and adult medicine, that these folks were not surviving 20 years ago the way they are now, and in much better shape. So I'm going to jump right in with my own question first. I'm going to take my moderator prerogative. So with one of the things that you brought up is this need for adult hematology, this need for transition of care, I think is the buzzword that people use, and this need for really a less fragmented system. What are some of the ideas that are put forth in Nasam as far as actual specific things that can be done now, and that we should be holding ourselves accountable for and bringing those forward?
Well, thank you for asking that. I think workforce issues are some of the easiest to address. It just takes the will to do it. HRSA, the Health Resources and Service Administration, who runs all the federally qualified health centers, huge programs for loans and student loan forgiveness, could really make this a priority, right? They could fund programs that if you get training, you basically get free residency, extra free medical school education, free nursing education. You can get loan forgiveness. If you work in an underserved area, you can get your loan forgiveness in 3 years. So all these things are very important to do. They started a 1-year fellowship in pain management that there are now 20, and I was very involved in that, just to give general practitioners a paid 1-year opportunity to learn how to take care of pain. We can do the same thing in sickle cell disease and other genetic disorders. Now, in terms of fragmented care, the demonstration model, there's lots of thoughts out there. The American Society of Hematology has a lot of thoughts about how to do this, but this sickle cell demonstration project was really good. What it was is it showed that you could have what's called a hub and spoke model, where you have a hub like a center like yours or Boston Children's or Mass General or all the big centers that had lots of spokes out in the community. So private care practitioners could actually be part, even though they didn't have their own hematologist on site, they were part of this vast network where people who could be taken care of in the clinic could be taken care of there. But the moment they needed transfusions or specialty care, they went up to that hub model. An expansion of that is great, particularly with all the telemedicine we have right now. This could really be a very easy solution, but we can't let the government only fund this program for $4 million a year for 14 years in a row. It's demonstrated tremendous success. Kick up the money, right? This is what we need advocacy for. This is an easy fix that could start down the road to improve.
I love how you say it's easy. I find that nothing with sickle cell is easy, but
Well,
it's
you
a
know,
great place
when
to start.
I say it's easy, it's not like trying to drive a gene therapy. It really is Congress with a stroke of a pen, just allocating the right money, because the model is there, the know-how is there. It just needs to be funded. Now, that's not always easy, but it's easier than developing a gene therapy and doing it through clinical trials. This is something that if there's a will and we can work on it, then it could be done.
That's wonderful. Again, it gives me chills. One of the things that we focus on for this summit is awareness of disparities. We've seen a lot of that actually come out very clearly with COVID, unfortunately. Given that sickle cell mostly occurs in people of color and those of Black descent, how do you see awareness of disparities in sickle cell disease, and how does it affect its treatment? And is that awareness going to be raised and be of benefit?
So I think it's underappreciated generally. I think people in the medical community have had an awakening about it over the last 5 to 10 years. But that's one Rita that's data is so important. When I asked CMS, Center for Medicare and Medicaid Services, to pull the data, remember, it's never been done nationwide. We had no idea what the quality of care was. We thought it was kind of bad, but we had no idea that only 1/3 of kids get an ultrasound that could prevent strokes. I mean, this is terrible. Kids have strokes when they're 15, when they're 20. This is an easy thing to do. It's pain-free. People are not on the medication. So one of the things I wanted to highlight is, if you have data, you have to deal with that. If you don't have data, people can stick their head in the sand and say, well, it's really not that bad, or we're doing a better job. But I really, one of the things I said is I want this every year. I think there should be a national report card for how we're doing with sickle cell, at least those in Medicaid, right? There are about 45,000 people suffering with sickle cell who are Medicaid covered. And we could do that from the federal level. And I think all the private insurance companies, I think they actually probably do a little bit better job at this than the Medicaid programs, because Medicaid, it's different in all 50 states. And the private insurance programs, I think, have caught on. Number one, it's the right thing to do. But if you care for people and give them good care, they stay out of the hospital, and they don't cost the plan. So it's really a win-win for everybody. But we need to shine a light on this, which I think is one of the worst health disparities in the country. It's very hard to solve all health disparities because you're dealing with people that start in impoverished areas who don't have employment opportunities. But sickle cell, I basically look at it this way: if we can't fix disparities for sickle cell, we can't fix disparities for anything. So let's start with this known population with great new treatments that so many people want to work with. Why not? This is the time to do it.
You make everything sound so much like common sense, but there is so much more to it. Like you said, you have to dig for the data, and then you have to do something about it. And how do you encourage everybody to do something about it? Which you have done a few things. What is the most innovative policy you have proposed or enacted in recent years that can reduce these healthcare disparities? And what kind of things would you hope for the future?
So, it's a very difficult question, and is the core question. And it's something that we started, but I want to introduce this. We call it value-based transformation, okay? And what that means is the current system pays people to do procedures. So actually, if a sickle cell patient has problems and go to the ICU, the physicians and everyone gets paid more because you do more surgery, you do more ICU. We have to change this around. And it's just starting, particularly in the older population, where we don't pay for doing stuff to patients, we pay for keeping patients healthy. I would much prefer to give you a check to allow you to provide food to your patients or transportation to your patients, or give them a mobile phone so they can call with help, or to empower the ambulance drivers to deliver care at the home when they go out and not have to bring them to the emergency room. So I think, this is a big thought, but I think we really have to change our healthcare system from paying for stuff that you do to people to paying to keep people healthy. And when we do that, then we can start, because the disparities just aren't in access to care. Disparities start with physical disparities in the community, the lack of food security, the lack of playgrounds, the lack of being able to play sports on teams. This is the kind of stuff that we spend 1.4 trillion out of Medicare and Medicaid out of the federal government, and probably 2% goes to that or less in this kind of holistic kind of help. And we need to make that mainstream. You probably have a better opinion on it than I do, but that's what I see we have to change in our system. It's not just about access to a system that rewards the wrong behavior. We need to have access to a system that rewards the right behavior, meaning rewarding physicians and healthcare systems for keeping people healthy.
You're such a pediatrician at heart, I can tell. Which is, again, the same feeling that I've had forever. One of the thoughts that comes to my mind is this idea of that sickle cell disease, of course, is a genetic disease, right? It, as you mentioned before. With this being a progressive disease, right? So there's a role for medications, things that change over time. What might be good when you're 5 may not be the right thing when you're 15, and may not be the right thing when you're 30. And then again, what do you think the role of cure is in this? If we talk about cure, be it a gene therapy or be it a transplant, how do we think about those differently in sickle than we might in another disease, such as a cancer or something like that? Excuse my dogs.
Oh, I love your dogs, and you're right. Not everybody with sickle cell disease probably needs a gene therapy, particularly the kind that we have right now that still requires a lot of, work, some marrow suppression and, some transplantation. So this is a big deal. Hopefully in 10 years, it's going to be like giving an injection in your vein and you're all done. And I do think we'll get there. But right now, what I'm really concerned about is that people aren't even getting the basics of healthcare. And if we can't provide them vaccines or get them on a hydroxyurea, how are we ever going to be able to provide them quality of care after gene therapy? And, by the time you're 18 and can get a gene therapy, I don't want you to have had 3 strokes and have had, kidney disease and damage. So this all works together. But, before you can do a flea flicker, you've got to be able to run the ball. And we've got to just be able to provide the quality of care as the baseline foundation. And then many people may not need a transplant. They may be able to live normal lives just with the kinds of therapies we have, but many people will need a transplant or gene therapy. And then in 10 years or 15 years, when gene therapy becomes as easy as just giving a shot, and I think it'll get there, then more and more people can get it. That's the kind of way I'm looking at it. But we need to take care of people's basic needs first. Get them vaccinated, see the doctor, get a transcranial ultrasound, don't have strokes. We could do a lot just with our baseline things. And then the people who need gene therapy, should be able to get it. And, there's only one thing worse than not having a cure for sickle cell disease, and that is having a cure and nobody can afford it and it's not given equitable. And that's what we're all afraid of, and why the Levitt Group is really working on this.
Thank you so much. We are 2 minutes from time. Is there any last thoughts that you would like to share before we sign off?
So first of all, I think everybody can do their part here. When you meet, everybody has a local office from their congressperson, congressman or woman. Just tell them you care about sickle cell disease. And it's not just about sickle cell disease, but which is important with 100,000 people. But, it really is sort of a marker for how our healthcare system is doing. And it's a marker for health disparities. And it's something that, we can't, it's not a pipe dream. We can do something about it now. So please get awareness in your communities, at your state and local level, Talk to your Medicaid directors about paying for this and how important it is. Educate people. Everybody can bring their awareness. And remember, we have elections every 2 years for Congress and 4 years for major things and 6 years. Make sickle cell an important part of these priorities, because a lot of it's science, and Bluebird and people like you are doing the science, but a lot of it's policy and funding. And we need both going together. So everybody do your part. And if I can ever help any of you in your organizations, particularly dealing with sickle cell, really just call me, email me. I'm right there. Anytime, I would love to participate or help in any way. I think you're on mute.
Sorry.
Okay, now you're off.
I am sorry that we're out of time. I missed some questions in the Q&A, but what I'm hoping is that if we stay tuned, I will see what I can do about getting these answers to the questions. Thank you so much, Dr. Gryer. This was amazing. Thank you, Black Women's Health Group, for inviting us to come and talk and hear a little bit more about sickle cell disease and what we can do about access and improving inequities. Thank you again.
Bye-bye now.